So I am here again with a new lecture of National Program for the Elderly Health Care. In this program, we will discuss about the elder, means why they are requiring the healthcare program, and then we will see the components or objectives of this national program for the elderly health care. Okay. So we will start with the national sample survey of 1986 and 87. There is one survey in 1995 to 1996 and another survey in 2004, and the compilation of all these surveys is showing that the burden of morbidity, yes, means the disease we have seen in this particular age group. So the burden of morbidity in old age is enormous. Okay, they are very prone for getting the diseases as the immunity is low, and age is also one of the factor. Okay, the body is not supporting that well. So the burden of disease is seen enormous, and that's why we have to think over it. Yes, non-communicable diseases, lifestyle related and degenerative. Okay. So non-communicable diseases means which are not communicated or which are not spread or transmitted from one person to another person. So there are these diseases are non-communicable. Example, we can say there are some lifestyle or degenerative, like Alzheimer is there, which is very seen in the old age. Okay, Parkinson's is there, which is seen in the old age. So these are the generative diseases, neurogenerative diseases or lifestyle related diseases, yes, are extremely common in older people. Okay, irrespective of socio-economic status. Okay, we are not saying here that rich will suffer or poor will suffer these diseases. It is regardless of the socio-economic status. Yes, that age group, the old age, is more prone for getting the diseases. Okay. Now disabilities are very frequent in this age group. Okay, unable to walk, unable to talk, okay, unable to do daily activities. So disabilities are very frequent, which are affecting the functionality in old age, okay, and compromising the ability to pursue the activities of daily living. Okay. Therefore, these all of the points we have noted from the survey showing that there is a need to think over it to make a program for elder health care. Now see, National Program for the Elderly Health Care was launched in 2010 in our country, yes, and expected family contribution for an amount of rupees 288 crores, including 20% of state share, was approved in June 2010. Okay, under the remaining for the remaining period of 11th plan. So there is a 11th plan near to the 2007 to 2012. Okay, under the 11th plan. Then there is another plan, 12th plan, which is for 2012 to 2017. These all plan are for the 5 years, like 11th, 12th, 13th. Okay, so they are in the serial. So for the 11th plan, it's for 2007 to 2012 5-year plan, and under this program we have decided the contribution of amount of 288 crores, which is including nearly 20% of the state share as well. The program is state oriented, and basic thrust of the program is to provide care, to provide dedicated healthcare facilities to the senior citizens. So we want to provide the basic healthcare facility or dedicated healthcare facility, means we required a infrastructure for the elder people. Yes. So see, first we'll see what is the goal here. Provide dedicated healthcare facility to the senior citizens, and those who are the senior citizens, so more than 60 years of age group. Yes, at various levels of primary health care, In the later of the slides, we will see how we have configured the infrastructure under the elder health care. So, see here the objectives. The first objective is to provide accessible. Okay. So, accessible means everyone should be able to get the services. Okay. It should be easily available. Okay. So, it should be easily available to these age groups. It should be affordable. Okay. So, there should be no cost barrier here. There should be high quality long term. Okay. The treatment we are giving, the facilities we are giving, that should be of a high quality. Okay. That should go for long. So, long term high quality care is required. Comprehensive and dedicated care facilities. If we are using the comprehensive word, what it means? The comprehensive means lot of things, means it is an integrated approach. Okay. We are using the prevention of the disease. Okay. How to prevent the disease in the old age, how to promote the health. Okay. Then how to treat the disease in the old age. Okay. Then the palliative care means the dedicated care which is given at the terminal stages or serious illness. So, these type of all of the events are included in the comprehensive part. Yes, prevention, promotion, then counseling, terminal care, all of these. So, comprehensive and dedicated care services to an aging population. Yes. Then creating a new architecture for aging. So, I told you in the start, I told you if we want to provide the dedicated care facilities, for that we require the infrastructure. That is why we are saying the architecture for aging. Yes. So, architecture for aging to build a framework to create an enabling environment for a society for all ages. As we have seen, we have a pediatric facility, okay, dedicated pediatric facility for the children's. We have the facility for the other peoples as well. Okay. We have the specialized facilities, we have the facility for treating the hypertension, the diabetes, we have for the trauma centers, okay, we have the cancer treating facilities. Similarly, we require the facility for the elder health care as well. Okay. So, there should be this means the architecture should be there, there should be the environment which is showing a society for all ages. See the other objectives. To promote the concept of active and healthy aging. Okay. So, active and healthy aging means if we are saying the elder health care, okay, it is not only we are preventing the disease at the elder age. What we are doing? We are also promoting the health. Okay. We are preventing the disease. We are not only curing the disease, we are preventing the disease as well. Okay, by giving the counseling to the old age persons, okay, the aged person. So, there should be active or healthy life. Then convergence of National Rural Health Mission. So, National Rural Health Mission NRHM, this mission is emerged. We have converged this mission with the Ayush. Okay. Ayush is Ayurvedic, Unani, Siddha and homeopathic system also. Okay. So, this Ayush and other line departments like Ministry of Social Justice and Empowerment, these all of the mission and the departments we have converged it with the national program for the elderly health care. Okay. So, that we can work more better. Okay. Now, see expected outcome of the programs. So, by launching this program we did in 2010, our expected outcomes are first setting up of 325 district geriatric units. We are saying the geriatric units means they are the dedicated care facilities. They will provide the care to the geriatric people only. Geriatric means the old age people, more than 60 years of age, with dedicated geriatric OPDs. Okay. So, all of these 325 district geriatric units will be with OPD, okay, outpatient department, where the aged people can come for the consultation with the physician, will take the consultation and then can go back to the home and can come for the follow up. Okay, this type of facility should be there. And 10 bedded geriatric ward in 80 to 100 district hospitals. There should also the IPD facility as well. So, we are saying the 10 bedded geriatric ward, okay, in nearly 80 to 100 district hospitals. That is the outcome we want to achieve by the end of the 12th plan year. Okay. Then setting up of bi-weekly geriatric clinics, okay, means 2 times in a week, at least 2 times in a week there should be that type of geriatric clinics, and rehabilitation units, okay, where the counseling sessions are given for the terminal patients, for the serious illness patients. Okay. So, rehabilitation or reviving the life again. Okay. So, that type of concept is provided in the rehabilitation units in all community health centers of selected districts. Okay. So, this is the outcomes we want to achieve from our program, national program for the elderly health care. Now, see the other programs here, other expected outcomes of this program is setting up of weekly geriatric clinics in a primary health centers of selected district. There should be weekly geriatric clinics at the PHC level, okay, primary healthcare centers. Then the centers which are working on the rural areas where the sub centers we are saying at the ground level, these sub centers should be strengthened properly. Okay. So, there should be strengthening of all sub centers of selected districts to provide with equipment for community outreach services. What type of equipment? The old age accordingly to the disease, means if they are not able to walk or if they are not able to listen properly, if they are not able to see properly, this type of equipment should be there to distribute them. Yes. Then provide training to staff of public health care system in geriatric care. And if we are saying we want the dedicated healthcare facilities for the elder care, we are requiring the infrastructure. So, for the infrastructure, who will work in those of the infrastructures are the doctors, okay, the nurses. So, these doctors or nurses or other healthcare professionals should be skilled in the geriatric care. Okay. So, there should be a training also for providing the proper geriatric care to the patients. Now, what are the packages of services? So, the packages of services are given in sub centers, the primary healthcare centers, the community healthcare centers, tertiary healthcare centers, regional centers. Okay. So, start with the sub centers which are in the lower of the hierarchies. You will see the healthcare infrastructure. So, sub centers, health education and home based care. Okay. Now, in sub centers, because they are the fundamental units of our health infrastructures, they are working on the ground level. Okay. So, from these of the sub centers, the doctors or the nurses or whosoever are working in the healthcare center, these sub centers, they will provide the health education. They will give the home based care to the bedridden elderly persons. Bedridden elderly persons are those patients, the elder patients who are on the bed, okay, and they are on the terminal stage maybe. Okay. So, bedridden elderly persons and provide training to the family health care providers. They will also provide the counseling sessions to their their family members. Okay. So, their family members can help to manage the health condition of their elders in looking after the disabled elderly persons. So, this is one of the basic facility which a sub center can provide, okay, health education or home based care. Okay. Then coming to the primary health center. Now, the primary health center will conduct weekly geriatric clinic health assessment. So, every week we will see there is there is assessment of the elder health, okay, by organizing the geriatric clinic, okay. So there will be simple investigation including the blood sugar level, okay. So the common diseases like the vitals can be checked, okay. The blood pressure can be checked, blood sugar level can be checked, blood sample can be taken, okay. So these type of testing facilities are here in the primary healthcare centers by organizing the geriatric clinic camp, okay. Then see the community health centers. So after the primary healthcare centers, on upper hierarchy we will see there are the centers which is known as a community health centers. So they are conducting bi-weekly geriatric clinic, organizing rehabilitation services, domiciliary visits by the rehabilitation worker for bedridden elderly and counseling to family members for care such patient, okay. So what the community health centers will do, they will provide or they will conduct the geriatric clinic, okay. And on those of the geriatric clinic, what the services they can provide? They can provide the rehabilitation services, okay, to revive the life again means, okay. Domiciliary visits means the visits which is given to the terminal patients, okay, the serious ill patients. So the domiciliary visits are provided to at the home, okay, means home based care services for the terminal patients. So these type of services can be provided by the rehabilitation worker, okay. And also the counseling can be provided to the family members for the for managing the health of the elder people. Then district hospitals are there. District hospitals have dedicated geriatric OPD. So they have a proper setup, okay. It's not like the weekly they are organizing, it's a proper setup of geriatric unit will find in the district hospitals. That's why we say dedicated geriatric outpatient department services, okay. Indoor admission facilities is also there, not only the OPD department, there is a establishment of IPD department as well. So that's why indoor admission means the admission of the patients in the hospital, that facility is also available through the 10 bedded geriatric ward, or there is a one ward you will see in the district hospital is known as a geriatric ward specific for the elder people, okay. Laboratory investigation facilities are there and rehabilitation services are there, okay. So district hospitals we can say they have the dedicated geriatric facilities. Then coming to the regional geriatric centers, okay. Regional geriatric centers means in a state level we will see there are some hospitals which are dedicated for the geriatric geriatric clinics are there, or geriatric services they are providing, okay, geriatric healthcare services they are providing. So those are the regional geriatric centers. They are providing tertiary care services, okay. If we are saying the tertiary care means all of the sophisticated techniques are there, okay, to manage the condition. Any serious condition can be managed in these of the regional geriatric centers, okay. So they have the OPD and they have the indoor admissions. They have the outpatient department as well as the facility to admit the patient in the wards, okay. They have the 30 bedded ward, as we have covered in the district they have the 10 bedded facility, yes. Here in the regional we will see the 30 bedded, okay, ward. Development of specialized human resource, okay. So here in the regional geriatric centers we will see the doctors are with the MD, okay, means they have the MD degree. So they did the MD course in geriatric medicine, specialized, okay. So they have the specialized training, or they did the specialized course in geriatric medicine, and they are doing also the research in this area, okay. So they are very specialized hospitals we can say, or very specialized centers for geriatric care. Now see this is one of the chart which is showing the categories of the staff, okay, and we have regional geriatric centers, okay, then district hospitals, okay, these are also the dedicated centers, and there is a community health centers, okay. So these three centers we have taken here: regional, district centers and community health centers. Now who are the staff available in these of the centers for the geriatric care I am talking about, okay. So first here is the professor of geriatrics, then assistant professor geriatrics, medical officers, nurses, physiotherapist, medical social worker, lab technician, yes, program assistant, hospital attendant, sanitary attendant, okay. These could be the staffs, these could be the categories of this staff. Now we will see the numbers of these staffs. So I told you in previous slide, regional geriatric centers are very specialized, they are providing dedicated care, okay. District hospitals are as well, they are providing the dedicated care, but regional geriatric centers are with a specialized or sophisticated techniques, okay. They are providing the tertiary care to the patients, to the geriatric patients. So see, the numbers are here: professor of geriatric 1 in the regional, but no in district, or CHC is also nil. Assistant professor geriatrics, we are seeing 2 in numbers in regional, whereas nil in for both of the district as well as community. Medical officers are there, 4 in number in regional, whereas 2 in district hospitals. Nurses are there in 16 number in regional centers and 6 in district hospitals. Physiotherapists are also available, okay, 4 in number and 1 in district hospitals. Medical social worker is 1, lab technician is 1, program assistant is 1, hospital attendant is 4, sanitary attendant is 4. So if you will see the categories of the staffs, all are available in the regional geriatric centers. And if you will see the third type of center here is the community health centers, you will see only the physiotherapists are here, and the total here is, you will see the 1, okay. So regional healthcare centers or regional geriatric centers, they are providing, that's why the dedicated care, because they have these of the staffs which are providing the care to the geriatric patients, okay. Then see, expansion of program during 12th plan period, okay. So if you will see here, the existing districts, regional geriatric centers and National Center for Aging People, okay. So NCA is also there. These are at the national level, these centers are very specialized centers, and at the national level they are working. So I will see the existing, means before the 2012, okay. So before the 2012, how many districts are, or how many regional centers are, or how many national centers for aging people we have under this national program for the elderly health care, okay. And our goal, we'll see in these of the years, our goal is to, for the 2012 to 2013 it is nil, but 2013 to 2014 our plan is to add 25 districts under this program, 4 regional centers under this program, means which program? The elderly health care program, okay, and no a national care center for the aging people. In 2014 to 15 we have the goal of 25 districts to add or covered in the elderly health care. Similarly 4 regional centers and 2 national center for aging people, okay. Similarly for the 15 and 16 we can see we have covered 75 districts, okay, more 75 districts under the this program, and 4 regional geriatric centers, okay, and NCA is nil. Whereas in 2016-17 we have covered 100 districts. So total if you will see, there are 325 districts we have covered under the under this national program for the elderly health care. 325 total districts are covered, okay, whereas 20 regional geriatric centers are covered and 2 national center for aging are covered. Similarly, if you will see the program activities, so what are the program activities which are under the district hospitals or the regional geriatric centers or the national center for the aging. So you will see these are the activities like institutions sanctioned till March 2015. What are the institution number which are sanctioned in 2015 to 16? How many are providing the OPD services? How many are providing the indoor ward services? How many are providing the physiotherapy services required for the geriatric care? How many are providing the equipments or appliances which are required for the elder care? How many are providing the drug and consumable supplies? How many are recruiting the contractual staff? How many are training their staff, okay, for the geriatric care? So their numbers are written here, and if you will see, you will find district hospitals are sanctioned more, okay, compared to the regional geriatric centers or national center for the aging, okay. So that you can see here from this whole of the chart. Now next is the institutions OPD services. So institution, here we have taken the district hospitals, community health centers, primary health centers and sub centers. OPD services is one of the type of services given to the geriatric people. Indoor admissions can be provided, means the admission of the geriatric people. Physiotherapy, home visit services, supportive devices given to the geriatric people for their daily activity, okay. So if we will see their numbers are showing how many elder people get benefited from these of the services, okay. So like if you will see, these number of elder peoples are getting benefit from the OPD services in district hospitals. Similarly, if you will see the numbers, you can find district hospitals is nil, means not applicable for the home visits, okay. Similarly, you can see for the sub centers, what the sub centers are providing. Sub centers are providing the home visits, okay. So their numbers you can see, 8,300 people, elder people got benefited with these home visits, okay. And if you will see the supportive devices which is distributed, it's nearly to 280 people, yes. So this is whole in this chart. I hope this is clear to all of you. These are some of the institutions here. You can see these are the regional institutes, okay, like BHU, IMS BHU, then Government Medical College, Trivandrum, Guwahati, okay. These are some of the hospitals or colleges, okay. Then SNMC Jodhpur, MMC, these all are the regional geriatric centers. MMC, JMC Mumbai, SICK, IMS Srinagar, AIMS Delhi. So they are providing services to these of the peoples, and these are the numbers of the peoples who got benefited. So OPD services are provided by BHU, OPD services are provided by Guwahati, JMC Guwahati, OPD services are provided by Bombay and Srinagar, like this. Similarly, for the indoor wards or physiotherapy, lab test which are provided for these number of peoples, okay. So I hope this is clear to all of you, and how the peoples are getting benefited from these of the services which are under this program. So thank you so much. We'll meet in the next session with a new lecture.